Hi, it's such an honor to be here. I'm Julia Martinez. I'm a researcher. I just want to say I appreciate what Lotus shared about how important it is to assure that data collection is both meaningful and, if possible, uplifting. Academic research often focuses on understanding problems so we can design solutions, but the initial focus on these problems can create some problematic blind spots to what's working well, among other things. So I'm going to share with you today a snapshot of our efforts to conceptualize and define person-centeredness in the field of elder justice. This project is still in process, so I'm grateful for the chance to share the reason for this work and a little bit of what we've learned so far, and I'm especially grateful for the partnership with the Full Frame Initiative. So our focus has been on elder abuse multidisciplinary teams, which we call MDTs. And if you don't know what that is, don't worry, I'll be explaining shortly. First, a quick acknowledgement that anything I say is not the opinion or position of our funder, the Department of Justice, and some background. Elder abuse is an act or a pattern of harm, neglect, or exploitation committed against an older person. Our best estimates are that 1 in every 10 older adults experience abuse each year. There's numerous responses to help elder adults who've experienced abuse. Because these cases and solutions are complex and span disciplinary boundaries, MDTs are a promising way to break down silos and to develop coordinated plans for older adult survivors. MDTs are really good at helping these siloed service systems communicate and work better together to create comprehensive solutions, in addition to being a forum for cross-agency training for members, which has a lot of value for the people who attend and potentially for their organizations. We did a national survey in 2018 and found out that the top priority of these teams was safety and protection, followed by self-determination of the older adults. No one respondent ranked older adults' wishes as a top priority, but they did say that the survivors' wishes were mentioned in the case discussions if they were known. And about half said that plans were changed sometimes if they opposed the older adults' priorities. So with MDTs, the underlying assumption is that breaking down organizational silos will result in better solutions and therefore improved outcomes for older adults. And in many ways, this is true. MDTs are capable at assuring the completion of interventions such as prosecution, guardianship, and restitution. However, as Kishana mentioned earlier, legal interventions don't necessarily equate to success in terms of well-being. One major challenge is that older adults are most often not included in these case discussions within the team. So teams most often don't have access to the older person to ask them how they're doing after the intervention. There's some really good reasons for this, considering public safety and criminal justice priorities, and also that many older adults whose cases are reviewed may have some levels of impairment and trauma that would make inclusion really difficult for them. However, some really big decisions can be made in these meetings, and we know how important choice and empowerment are for well-being. So it's worth making sure that this is facilitated whenever possible. And so just briefly, what is person-centered care? I know I'm showing you a lot of words right now, 2 different definitions of person-centered care, but I want to emphasize 2 things. First is just the general concept that, that it involves the inclusion of needs, values, and preferences. And secondly, the difference in these operationalist definitions. The first definition was developed by physicians, and it specifies the importance of eliciting these preferences and that they become central of the care plan. The APS definition, Adult Protective Services, frames person-centeredness as a consideration. And there are no details on how this should be done or what to do in preferences, but against safety. And this isn't to say that the medical definition is applicable to elder abuse interventions, but I think we could do a better job about outlining the specifics. Because the reality is we don't know what services designed by older people would look like. However, there are some clues. When older adults who experienced abuse were asked about their perspectives and what would be helpful, here's what was found. First, they may not identify as victims or having had experienced something called abuse. And what they want would include several of these things: a sense of purpose, hope for themselves and for the person who's harming them, to be heard and believed, advice from peers, to maintain autonomy in relationship with the person who's hurting them, and to avoid facility placements. So the takeaway is that teams focusing primarily on protection and safety may not be equipped to naturally include or consider these needs. That's not to say that MDTs aren't using person-centered practices or approaches. I've seen with my own eyes some practices that do a great job of including the older adult's voice. The problem is there are no guidelines. And it's also unclear which situations person-centeredness may not be feasible. So this is where our work comes in. We've designed a 3-step process of outreach to experts in elder justice across the country to better understand what practices are out there and what the limitations are to person-centeredness in the context of these teams, and also to learn about what tools and trainings are needed. In May 2023, we convened a group of 25 interdisciplinary professionals with vast experience in elder abuse and MDTs to offer some workshops and learn about person-centered practices that do exist and discuss those that could and should be developed. We also learned about existing barriers. We're in the process of administering a questionnaire to teams nationwide based on what we learned from the convening to see what the perceptions of person-centeredness are and the prevalence of specific practices being used and what the barriers are out there. What we learned from this survey will inform a national symposium, which we're planning for March next year. We'll be inviting MDT members from all across the country to share what we learned and to workshop discussions that will lead to more concrete guidance. What we're envisioning is essentially a catalog of approaches and practices, training and policy recommendations to help reduce barriers. So I may be running short on time, but briefly, I want to share some things that we learned in the convening. We surveyed the participants and asked an open-ended question about elements of person-centeredness that they envisioned in MDTs, and their results branched into 3 themes. First, values, meaning foundational principles that are important. Secondly, mechanisms. What are the concrete activities and things that you can do? And third were considerations, which I think this is the most fascinating part, but recognizing that we all have a limited lens of looking at the situation. What other things might we consider in order to more clearly understand the situation? And I think this relates with a lot of the other presentations that were shared today. So this is being recorded. I'm not going to read these for you, but here's some of the values. And if you want to check back on this later or take a quick screenshot, here are the mechanisms in no particular order. And also some of the considerations. And I think what's interesting here is individual definitions. What an outsider might define as safety might be very different from the way an older adult might define safety. And I think that's a crucial finding. So I want to close by acknowledging the critical importance of including older adults' voices, and something I think our field could do a much better job at. But from what we've learned so far, person-centeredness is not an either or, but it exists on more of a spectrum. Some of the challenges stem from organizational culture and perceived or actual resource limits. And we know enough about what may be important to older adults, and that just having a variety of professionals discussing solutions may not necessarily incorporate or prioritize those needs. So here's my email. Feel free to reach out if you have questions or want to share ideas, and stay tuned for updates. I hope to be able to share in a year's time some of what we learned. Thank you.